Next is very interesting topic, that is mineralocorticoid receptor antagonist in heart failure, particularly REF. This is by Dr. Sandeep Bansal, please.
Good afternoon and thank you very much. I hope I'm audible and my slides are visible.
Yes.
Thank you very much. And after these two very interesting drugs, which are the latest pillars in the management of heart failure, my job is to answer this in the questions as we go on. Why do the MRAs benefit in heart failure? That is the first question that comes to my mind. And as we can see this slide, the bottom right, actually, the mineralocorticoid receptors are present in the kidneys, they are present in the blood vessels, and they are present in the central nervous system as also in the autonomic nervous system. So in the kidney, they cause sodium retention, potassium depletion, and microalbumin. The MRAs, these benefits are accrued to the patients. In the blood vessels and heart, they cause in the nitric oxide, they increase the reactive oxygen radicals. Therefore, they can lead to increase in adhesion molecules, vascular inflammation, and fibrosis, and that leads to sudden. So I was talking about this fact that the MRAs attenuate the ventricular remodeling. They reduce the level of biomarkers of fibrosis and ventricular dysrhythmias. Why should I use the MRAs? We already have a lot of evidence. We know that MRAs come right in the center of the management of patients of heart failure. We can see it over here. We also know that among the drugs which reduce mortality, MRAs are an important component of that. We also know that when we compare it with the agents that reduce mortality, mineralocorticoid receptors, antagonists, they cause a good quantum of benefit as far as the reduction in mortality is concerned. In fact, there was a paper about 8 years ago in 2014 by the Heart Failure Association of India, which said that if we give guideline-directed medical therapy to all the patients, the benefit accruing from MRAs would actually, be equal to or be higher than that which is accrued after the device therapy. We are all, as cardiologists, fond of devices and device therapies. But if we give MRAs to all our patients who deserve, then the benefit from device therapies would be just, the MRAs would be just as good. If we look in the terms of NNTs, look at this fourth column in this, and what we find is if you give it to 9 patients over just 2 years, the benefit is there in terms of reducing the mortalities. And this is comparable, rather much better than all other forms of therapies. What is the evidence in heart failure? These are these 3 important trials that you're all aware of. The RILES trial, which was in stable symptomatic heart failure, class 3 and 4. The Ephesus trial, which used Phenerenone in post myocardial infarction, approximately 3 to 14 days after MI, and the Emphasis trial, which was in both ischemic and non-ischemic stable heart failure using Phenerenone. As far as the RILES trial is concerned, this is just recapitulating that about a 1,600 patient study, and what it clearly showed was that there was a whopping 30% reduction in all-cause mortality. The sudden death was also reduced by about 30%. Progressive heart failure was reduced by about 36%. So great degree of benefit in stable heart failure. The Ephesus trial using Phenerenone actually showed that the total mortality was reduced by about 15% and the cardiovascular mortality by about 17%. in patients who were post-myocardial infarction patients and were randomized to receive with LV dysfunction and were randomized to receiving eplerenone 3 to 14 days after their index event. And so, and they were extremely safe. It was absolutely safe. There was numerically a higher degree of hyperkalemia as was expected, but that is it. As far as the FSS trial was concerned, again, 2,700 patients were randomized to receiving eplerenone versus placebo. And what we find is that the primary endpoint showed a significant 37% reduction. And almost all the secondary outcomes, the individual components of the primary outcome, were also statistically significantly reduced. So no wonder then that MRAs are a very important drug group in our armamentarium. What is new? The new thing is Phenerenone, which is a non-steroidal MRA. We are aware that both eplerenone and spironolactone are steroidal MRAs. And in terms of potency and selectivity, both are very high with Phenerenone, and that is the drug that the world is looking for. We find that potency and selectivity are high, and the tissue distribution is quite balanced. The other ones, the spironolactone and eplerenone, they are higher in the kidneys, but this is balanced both in heart and in kidneys, and in future trials, we shall be seeing this. There are two important trials. They are essentially in chronic kidney disease. One is the Fidelio trial, which looks at the kidney point primarily, and the Figaro DKD trial, which actually primarily looks at the cardiovascular endpoints. As far as the Fidelio is concerned, the renal benefits accrue quite clearly, 18% reduction. And so is actually the cardiovascular benefit, almost a 15% reduction in the primary endpoint in the Fidelio trial. In the Figaro study, which looked at primarily the cardiovascular benefits, again, a 13% reduction in the composite of cardiovascular death, non-fatal MI, and hospitalization for heart failure. Now, why am I telling about this drug? When this drug, this is none of these trials was actually in heart failure group. The main thing is that the major benefit that accrued because of MRAs was in terms of reduction of hospitalization for heart failure. So we do reduce heart failure if we use Phenerenone. The evidence presently is in patients who have chronic kidney disease, but by and by we will get more and more data. Now, what are the additional questions? Can we use MRAs early after myocardial infarction? And can we use them in patients without heart failure to prevent heart failure? This evidence, as I showed you, is already there in patients with chronic kidney disease. In FSS, as I said, the inclusion time was 3 to 14 days. But what was seen was that if you divided them into two groups, those who were started on 3 to 7 days versus those between 7 to 14 days, a greater benefit was seen in those who were started these trials early. So people did different trials. People did a trial called the Reminder trial, in which eplerenone was started within 24 hours of myocardial infarction, and in those patients who did not have clinical heart failure or left ventricular dysfunction. What was seen was that the composite endpoint was reduced, but it was only by way of reduced BNP and anti-proBNP levels. There was another study which was called the Albatross trial. This actually did not show an overall benefit, but what was seen was that in patients with ST elevation MI, the benefit was seen, and not in patients with non-ST elevation MI. So there is an analysis which was published of MRAs in STEMI patients started very early on, within 24 hours, and in patients without left ventricular dysfunction. And what was that both death and the composite of death and resuscitated sudden cardiac death were statistically significantly reduced. So we have a reasonable evidence that the benefits accrue even if the patients are started early on in their course of. Thank you for your kind attention, and any questions, I'll thank you very much.